So how do we begin? The main thing is to reduce tension in the Achilles by any and all means. And this is going to involve multiple specialists, could be podiatrists, could be physical therapists, could be massage therapists. Hi, Dr. Pelto here. What I'm putting together here is just a kind of a quick review about our online webinar that we did at the office, all about Achilles tendonitis. The webinar is quite long, so I'm hoping to do an abbreviated one here. There is the full length where it has all four of the doctors, but let's get right into it. What is Achilles tendonitis? Basically, Achilles tendonitis is a condition where there is pulling and micro tears on the back of the Achilles tendon. You can see kind of right in this area here. And what you're going to find is that these tears can eventually become thickening and causing a tendinitis, or what we now know as a tendinosis. And most of the reason for this is because this specific area is called the watershed area. Basically, it's an area that doesn't get the best circulation, and it can be problematic for our patients, causing some type of a tear, micro tears. And another reason is that the area of the insertion down here, this can also be caused because of a spur and what we call insertional Achilles tendonitis. What are the causes of Achilles tendonitis? The main cause is poor postural habits with core weakness and all that implies. Basically, if everything is unstable from the top going down, for example, your core, that's going to affect your muscles, your quads, your hamstrings, going down to affect the Achilles. And this can either be at the knee level, at the pelvic level, at the hip level, and this can happen over time. It doesn't usually happen really quickly, but all the problems that kind of lead up to causing this. It can also be caused by increased walking or running, changing of your shoes, going basically from a shoe that has a 10 millimeter lift or a higher lift to something that maybe is a minimal shoe. We see a lot of patients now, they're at home a lot more barefoot. Weight increase can cause it, and then lack of foot strength and dependence on shoes. These shoes, once they get older, they can also aggravate the Achilles tendon. What we'd like to show here is that the gastroc and the soleus that form the Achilles, they both cross the ankle joint and the knee joint. And this is what we want to show. If you can see here, the gastrocnemius, it originates in the knee, above the knee region in the lower area of the femur, and then it goes down, combines with the soleus, and inserts into the foot. So if you can see both of these, they start above in the lower thigh and then insert into the foot. So they both affect the ankle joint and the knee joint. That's what we want to show. So the knee and the ankle position are very important. Therefore, if your knee is kind of curved in, if you're pronating quite a bit, flattening in at the ankle joint, that also is going to affect over time your Achilles tendon. And we also want to show here that what tones the hamstring also tones the gastroc, and it adds tension to the Achilles. Once again, it's not working in isolation. Achilles tendonitis isn't in isolation here on the back of the calf region. You can see here that the position of your pelvis up here is going to affect the hamstring and the tension on the hamstring. So if you can imagine, if there's tightness in the hamstring, there's also going to be tightness in the Achilles. If there's loosening in the hamstring and the pelvic position causes it to loosen, there's going to be loosening in the Achilles. So this is something that we don't see that much, is loosen. We actually see things that are more tight because of our society and sitting down more. What I'd like to show here is that the muscles that are involved in posture, the focus that we have is fixing or helping to fix with posture, both with what we can do and what physical therapy can do and other types of professionals. So what you notice here, there are what we call extensors, and then there are flexors. So that we have the posterior chain and the anterior chain. So the posterior chain starts in the neck region, the iliopsoas, gluteus maximus, your butt muscle, the hamstrings, and the gastroc. So what we're talking about is the gastroc soleus, which makes up the Achilles tendon. But if the hamstrings are tight or anything else is tight up in this area, it's all going to kind of transfer down, okay? And this has a lot to do with your pelvic position, okay? Specifically, we're going to talk about how an anterior pelvic tilt is going to affect this and make everything kind of tighter and pulling more on the Achilles. And what's fighting against the posterior chain is the anterior chain. So this chain in the front with the neck flexors, the spinal flexors, quadriceps, and tibialis anterior. These kind of all oppose these. So if one is overpowering the other, it's kind of like a tug of war, whatever one is stronger. And we want to focus specifically and show kind of how the pelvis affects this. Normally, the pelvis should be totally rectus or just kind of straight or neutral, in a neutral position. That would mean that the anterior and the posterior chain are kind of equal in equilibrium. Sorry. And but what we see here with an anterior tilt of the pelvis, so the pelvis tilts forward, okay, and this actually causes these to become shortened and these to become long. It's the contrary on the back. So if this is going to be long, this one will be long. So the lengthening of it here is actually shortening of it here. And these are the quads that we talked about. So if these are short and tight, and what causes this many times is that our society, now that we're sitting so much, when we're sitting and putting our kids sitting, and we're putting our kids in shoes with a lift on the heel, that's going to cause different types of issues. And specifically, it's going to cause these to become shorter and tighter here in the back, and these are going to be long. And what happens, that causes even more anterior tilt, and that can cause these to be shorter and tighter, and that can affect everything. And these become weakened. You become more and more weak, which can also affect your Achilles tendon region. So what are the treatment options? Well, most people, they don't even know they have it until they get Achilles tendonitis, and then you can ignore it and hope it goes away. You can try non-surgical treatment, which we try to do most of the time, and then there are some indications for surgery. So how do we begin? The main thing is to reduce tension in the Achilles by any and all means. And this is going to involve multiple specialists, could be podiatrists, could be physical therapists, could be massage therapists, and other types of tools and treatments. Avoiding positions and shoes and activities that increase discomfort. Okay, so avoiding a lot of sitting down positions, kind of working on the pelvis, the position of your pelvis, loosening, and also shoes that are more neutral instead of elevated heel and things like that. And the key is to really get stronger, getting stronger in your pelvis, in your hip position, in your core, you could say. And then we want to keep people active. Sometimes it's hard when you're in a lot of pain, but we try to keep people active. And really, we want to actively prime and recover the gastroc soleus in the Achilles. We want to prime the muscles for activity, kind of get them used to activity before you go into the activity. And so first we're going to talk about how to reduce the tension in the area of the gastroc soleus. This is also going to need to be done for the quads, for the gastroc and everything else, kind of the quads and the hamstrings as well. What I want to show is that stretching is really overrated. When you talk about these muscles and these tendons, stretching a lot of times causes these to contract when you're stretching them. It's kind of a response. And so sometimes what works well and what helps is something called neural detoning. And in the other lecture, Dr. Feldman talks a lot more about that, but it kind of turns off that stretch reflex. When you stretch it, it tightens. So by doing neural detoning, this area right at the insertion, you can kind of rub it lightly, and that can kind of cause this neural detoning and kind of everything to relax. You can also do an isometric stretch or an eccentric stretch. So eccentric would mean kind of going against the grain of how the muscle fires. And other thing that can help quite a bit is reducing the tension and the tone with some type of thing to work the back of the calf, also the quads and the ITs and everything else like that. The benefit of foam rolling versus stretching is that foam rolling increases the blood flow and helps to prime the muscles prior to activity and help them to recover after activity. So both pre-foam rolling and post-foam rolling activity is very helpful. If you're having a lot of pain, certainly to reduce the inflammation, icing can be done. You can take a different, formats of the bottle of water, things like that. You can also alternate between icing and hot water. This would be contrast baths. So you do 5 minutes of ice, 5 minutes in hot, and then 5 minutes in ice. So you always start and end in the ice water. Certainly anti-inflammatories can be taken on a short term, but a lot of times they're not long term. That's not the best option. And then reducing the tightness here, this can also help for different types of patients. There's a couple ways of doing it. One is with a towel stretch that can be done prior to getting out of bed. There's also a device called a night splint that can be helpful for this as well. Heel lifts can be used temporarily. Once again, if you're in a lot of pain, what these do is they don't really reduce the tightness, they reduce the tension and the pull on the back of the heel. They don't resolve it, but they can be used in a short term. I don't recommend using these long term because these can be problematic. And then if you're in a lot of pain, some of our patients, we temporarily put them into like a walking boot. Once again, if you ever have to go in a walking boot, try to get in one of these even up things for the other side. Basically, it keeps your hips at the same level and reduces a lot of other problems. Orthotics can be used sometimes. The primary role, though, of an orthotic is to assist posture and not purely an arch support. So you want to correct the posture. As we talked about, depending on the knee position and the ankle position, that can change the pull, as you can see here on the Achilles tendon, because of this the postural position here of the foot. That's going to change the pull on the Achilles, and for a lot of people can cause that pull and inflammation. Good shoes can be helpful. Once again, an insert, people try that before they come and see us. And then physical therapy is a big component. You can do both on your own and also at physical therapy. I don't recommend trying any of these. These are a couple of other devices that can be purchased on Amazon to do this. You have to be trained by a professional of how to do this. This is going to be loosening the tightness in the back of the calf. And that for a lot of our patients can really, really help reduce the pain. The x-rays that we do, we get x-rays to see if there is any spur in the back of the heel. We're going to go on to kind of how we make the diagnosis and look at other issues. Sometimes bone spurs with an insertional Achilles tendonitis can be caused because of the bone spur, and there are some surgical things that needs to be done. You can see this big bump on the back. But for a lot of our patients, the pain is actually above where the bone spur is. I find that an ultrasound exam really, really helps, where you see the spur and the Achilles coming down. You can look at the fibers and you look for areas of black. So white and gray on an ultrasound is okay, but black is bad. And you want to look at any area. This is kind of an uptake flow area, and this black area would be an area of an effusion or some type of a increased liquid inflammation in that area. And this will kind of guide our treatment. Here's an example of a cross section as if you're cutting through an Achilles tendon, and you can see it kind of looks white and gray, but this little area here looks more black, and that would be an area of an effusion. Once again, you can see the fibers of the Achilles tendon as it kind of comes down, and then a little black area here in the center. Black area and effusion around the tendon. And here's some thickening. A lot of people have thickening of the Achilles, and that's an example of that bulbous. It looks like a bulb, kind of bulbous changes there. An MRI many times is needed as well. You can see if there's any tear with it, or just the thickening, or how bad the tear is. Here's a frank tear of the Achilles tendon. Usually you don't need an MRI to determine that. You'll be finding that out, and that's something certainly you need to talk with your doctor about if you're concerned about a tear. Another example of an MRI, here's a normal MRI, a normal view, and then here you can see fluid around the peritoneum, this area around the Achilles tendon that shows that. So there's different areas. You can have inflammation inside the tendon, you can have a tear in the tendon, or kind of an effusion or swelling around the tendon. And here is an example of a bursitis of the Achilles. So basically an area behind the Achilles. This is a bursal sac, and this patient also has a Haglund's deformity, a bump on that, and that aggravates the Achilles and all that in that area. So there are different types of treatments that can be done for that. Talk a little bit about regenerative medicine here. This was a portion that Dr. Savia did very well in the longer lecture. But basically, regenerative medicine is a process of replacing or engineering or regenerating human or animal cells, tissues, and organs to restore or establish normal function. And we use regenerative medicine a lot these days. One of the most common ones that we use for Achilles tendonitis is shockwave therapy. And basically, what it is, shockwave uses either focal or radial shockwaves. And most of us have machines to start out with that is a radial machine. And basically, it starts and it propagates over a larger surface area, focusing at your target. And this is this example of a radial machine right here, and it produces these shock waves, and you treat the area of the Achilles tendon. What you basically do is Achilles tendon, if there's not enough blood flow to the area, it can become stalled. It should heal, but it doesn't. And by shooting these radial shock waves at it, it can propagate that healing process and start kind of this whole cascade of healing in the area. We tend to do between 3 and 6 treatments of the shock wave, 1 to 2 weeks apart for our patients. There is also a focal shock wave, which we have in our office as well. And basically this focusing at one point, and it's used in conjunction with the radial shock wave to help bring and stimulate the healing. This reduces, by using the combination, reduces the amount of treatments that you need, because they kind of work differently by focusing in there. It works with a mechanical transduction and kind of focusing on transferring that energy into your Achilles. When should I consider it? We consider it pretty much first line, because there's really no downside to it. And a lot of our patients have tried the other treatments first. Certainly if you haven't tried icing, anti-inflammatory, stretching, things like that. The main problem is it's operator dependent. You have to know how to do it, how to get good results. And the lawn care analogy is basically, when you talk about regenerative medicine, if you have a problem in your lawn, what the shock wave is kind of like is kind of like core aeration, where you kind of core aerate the area and then you throw seeds on it. So it uses the your lawn itself, doesn't really change anything, but it helps propagates the healing. There is also platelet-rich plasma, and this is basically where you take your own platelets and you spin them down, and you get the platelet-rich plasma, and that you inject into the area. And that can be done in the office. You have to inject the right stuff, which is the plasma that can help the healing. When should you consider it? Really, if other things aren't working, we don't do this first line usually. It's usually shockwave first, and then we could consider this in the future. The problems are really operator dependent of where you put it. So this is done with a diagnostic ultrasound. It's patient dependent. Once again, younger people have better platelets. Older people have less good platelets. And so if you're older and you're unhealthy, you may not have a lot of good platelets. The literature is also mixed, whether it works or not. It really depends, once again, on operator dependent. And inaccurate injections is really the main issue. That's why I think diagnostic ultrasound is essential. The lawn care analogy for this is basically, this is like taking one portion of the lawn and kind of putting it somewhere else. So basically you take out a piece of the lawn, put it in that area that's bad, and replacing it with your own lawn. Okay, that's how that would work. And for a lot of people that works well. Amniotic tissue injections, what this is, well, it's preserved placental tissue. Basically the placental tissue from a full-term birth is very, very healthy and has a lot of good healing components to it, and it is injected in there. It's freeze dried. We actually, this is a liquid we use here now. It takes that right stuff and it puts it right in the area. So what we tend to use this for, what I tend to use it for, is an area of the Achilles where I see that black, and then I can inject this right in the area to help bring healing. It really speeds things up. That's the main reason. It can be done in conjunction with shockwave as well. It's very operator dependent. Mixed literature as well, but less than PRP. So there's a little bit better literature on this than for PRP. And once again, inaccurate injections, that's where the main issue is. This is like liquid gold, so you want to do this with a diagnostic ultrasound as well to get in the right spot. The lawn care analogy for this is you want to take kind of like a Miracle Grow, you know, and you put it right on the area, and that's just going to really, really preserve it. Or you could even take some turf from one of the professional lawn care periods and just put it right in there. So it has all the right stuff to help it to heal. This is an example of amnio and kind of how we use it. It comes, we pull it up and we inject it right in the area where it's injured. The question here, is there any evidence that a second round for a year or more of EPAT can further reduce Achilles pain? Yes, it is quite beneficial to do a second round. Sometimes people need more than the typical 3 to 6 treatments, and a second round can be beneficial. I would probably recommend an ultrasound prior, just to evaluate that area to see if that would be beneficial for you. Next thing we're going to go into are the surgical options for this. Mainly we're speaking of the Haglunds, right? There's not a lot of that we do for the Achilles itself to repair it unless it's torn. But for the Haglunds, what we do is we remove a part of the bump and then reattach the tendon. And sometimes we have to do a FHL tendon transfer to help augment or to help increase the strength of the Achilles. Sometimes loosening or cutting through the gastroc can be helpful, and then the topaz can be useful. Once again, the topaz makes little micro holes, and there are some other procedures as well. So let's look here. This is an example of a pre and post-op. Basically, this is the bump in the back that was really causing aggravation along with the spur, and that was removed here. And that's a surgical procedure, and these little lines here are where the implants were. These are non-metallic implants that kind of absorb over time. Here's an example of a gastroc recession. This is a kind of a arthroscopic way of doing it. And you can also do it open. This would reduce the contracture of the Achilles. Doing a FHL, or flexor hallucis longus. So this is a tendon that can be taken and inserted and help kind of strengthen the Achilles pull. And this can be used in some people are concerned because you take it from the big toe joint, but there is a connection here at the knot of Henry, and that usually is not a problem. So you can take this and help to strengthen the Achilles tendon. There's a topaz procedure. This is basically little micro pokes in here that can be done, and this can help increase the blood flow and help bring healing. This can be done as well. And then there is the 10X procedure, which uses an ultrasound to find the area, and that area of bad tissue, you use an ultrasonic debrider, and it takes out any unhealthy tissue and it preserves the healthy tissue. That's how that works. And really the recovery and the goals and the expectations. This is an example of the speed bridge procedure where you cut through the Achilles, take off the bone spur, and then reattach things. The tendon itself is going to take 6 to 8 weeks to 12 weeks to heal. We want to work on range of motion to not lose any range of motion during this. People are going to be walking at about 2 months. You may be in a cast for 6 to 8 weeks, and then running in sports at 3 to 6 months. How to prevent Achilles tendonitis? Basically, the main focus is with your activity, doing that preparation of the soft tissue work with foam rolling to the quads, IT, calf region, and then focusing on the alignment and your posture and strengthening the intrinsic muscles in your foot. How to prevent a tear when you've had continued aching. Once again, it's the same thing. The tear isn't all that common. You could have little micro tears, but an actual tear is usually propagated by some type of an activity, like a jumping activity or going for a layup or something like that for someone that's not that active. But preventing it, you just have to be careful, and don't just go out and do like the weekend warriors. Those are the more ones that get it. Those that go out and never do anything, and they go and play 2 or 3 games of basketball. And can chronic Achilles tendonitis be resolved? Yes, there are treatments to help resolve it. So once again, I hope you found that helpful. On the bottom of this video, I'm going to put some other resources, link to the slides, link to the other video, the full video if you want to hear the other doctors, that these are their slides that they did. And I just kind of abbreviated it because it was kind of long for the hour-long. People are kind of busy. And I also put a link to some books and other resources. Okay, hope that was helpful for you. Thank you. Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.